it's important for us to take charge of our health. I think somebody had the analogy about for those who drive, and they said we treat our cars better than we treat ourselves, because every couple of miles you take it in for a service, right? Whereas with our bodies, we wait for the car literally to break down, and then we tow it, to the hospital for care. So what can we really do in terms of sort of getting ahead of the game and taking charge of our health? So the two things that ultimately make a difference, Mikal, are diet and exercise. Those are the two key things that you can do to modify your risk. So my name is Miriam Mutebi, and I'm a breast surgical oncologist, which is a breast cancer surgeon, and I'm also a clinical epidemiologist and a health systems researcher, which is a big name to say my research interest is on understanding barriers to care for women who have cancers in our region and designing interventions that talk to those barriers. Today, I think we're super excited because today we're seeing the launch of a breast cancer action plan, which has been, I think, one of those really big strides in terms of operationalizing cancer care delivery in our country. We've had a very, I would say, active and engaged National Cancer Control Program. And part of what they've been doing over the last couple of years is trying to design screening guidelines, diagnostic and treatment guidelines, looking at how those percolate into patient care. But then now this marks going beyond the guidelines, but then seeing how do we then put this in practice. So I think it's a very exciting moment for the country, and we're looking forward to seeing how we can best support this as we go forward. Perhaps I would give a sense of what's happening in the country, because again, it's important to sort of have the context of what's going on throughout the rest of the country. And I think what we're seeing is that, we've definitely made quite a number of strides in the last couple of years for sure. But what we've seen is that, as you said, about 70% of patients are diagnosed with advanced disease. I think if we sort of look at a deeper dive into the reasons behind that, we almost see like a constellation of three main factors. One, the fact that the finances patients have to pay out of pocket. I would say, mad props to the National Hospital Insurance Fund. Over the last few years, we were actually seeing more patients, completing their treatment journeys. Whereas what used to happen, Mikal, I would say, maybe about 10 years ago, for instance, was you would get patients sort of coming in, maybe getting the preliminary treatment, and they get lost because to follow up because they've gone to maybe fundraise and come back for more. But definitely the fact that the National Hospital Insurance Fund is helping to bear some of the costs has actually made us see a lot more patients going through. It's still not 100% perfect. There's definitely things that need to be done in order to sort of tweak how that runs. But that's because still, and I would give an example. For instance, the fund may sometimes you need, say, 8 cycles of chemotherapy, and maybe the fund can only cover half. So then you're sort of left trying to fundraise on your own. And so for some patients, for quite a number of patients, this results in what we call financial toxicity and catastrophic health expenditure, meaning you break the bank and you're not necessarily able to not only sustain your treatments, but even your livelihood and that kind of thing. So that's one of the major factors that we see. The second broad factor that we've seen, certainly in Kenya and throughout most of sub-Saharan Africa, is health systems sort of delays. And sometimes what happens is it can be both from a infrastructure perspective, in the sense that patient needs to have a diagnosis done, but they have to pay out of pocket for their diagnostics, or you have to have a CT scan to stage your cancer and you don't have access to those funds. So those invariably cause delays. One of the other major sort of speed bumps that sometimes patients get, certainly in sub-Saharan Africa, is that sometimes you would see on average 3 to 4 clinicians before, or health workers, before a diagnosis, a definitive diagnosis of your cancer is made. And so sometimes people are falsely reassured. You're told, no, you have a lump when you're breastfeeding, it's nothing to worry about, or maybe it's an infection, have this, treatments and stuff. And so all these ultimately result in delays. And I think one of the areas that, Mikhail, we don't necessarily talk often enough about, which is the third major barrier, is the social cultural aspects of care. Now, this is because one would see that in many parts of Kenya, for instance, women are not necessarily the primary determinants of their health-seeking behavior. And as such, they require either a partner or a spouse to give financial support, or sometimes even permission in order for them to access care. The other thing is that there's lots of myths and stigma around cancers. Sometimes patients who have cancers get shamed, for instance, especially reproductive cancers, things like breast cancers, cervical cancers. You're told, you must have had it because you were maybe of, dubious character. So those kind of things that actually help to, enforce or stigmatize patients also make them reluctant to engage or actually seek care. Some of the other things are, again, the social implications of a diagnosis. Some people go home and they say, honey, I have a cancer, and you're told, honey, there's a door, don't let it hit you on the way out. And so while many partners are able to support, their spouses and stuff through a cancer diagnosis, for some, we sometimes say, telling a lady in sub-Saharan Africa that you have cancer doesn't mean you have cancer. It means you have cancer. You could potentially lose your source of livelihood. You could potentially lose your family. So these are very huge implications. The other thing that we also see is, again, in certain communities, there's a fatalism around cancers, because the narrative has always been, Mikhail, that you get cancer, you die. So why would I go to get care? And of course, there's lots of alternative therapies. People want to go and try miti shamba and stuff. And so all these ultimately result in patients having a delay at the time of their diagnosis. I think we've had definitely an evolution during the pandemic in terms of the way we deliver care. I think at the initial start of the pandemic, there was so much uncertainty around what was happening. There was a lot of, we always say there was an infodemic. There was so much information, lots of uncertainty, not just for patients and even for the health workers who were delivering care and wondering, am I safe to go home to my family? The biggest thing, and then of course we had the lockdown, so patients sometimes were not able to travel long distances to access their care. And so the first thing that we saw initially was a major sort of halting in all cancer services. Cancer surgery, for instance, initially there was a declaration about stopping all elective surgeries and maybe just doing emergencies. And then of course that leaves cancer in the middle. Like, it's not an emergency. Like, you don't have to have your surgery in the next 2 minutes, but it's planned, but it's semi-urgent. But then it was sort of falling through the cracks. Like, where do we put this? Again, patients were not able to come through. Again, most of the things like radiotherapy and that kind of thing are in urban areas. So looking at how do you get patients moving to these centers, and all those were compromised initially. But I think one of the major things that we picked up, Mikhail, especially over the pandemic, and what we've learned is, we always say in the middle of adversity, there's always an opportunity, and there have been silver linings. I think the biggest thing that has changed in terms of our care delivery is we've all been forced to think about how do we deliver care when we're not necessarily able to access patients. And so this has made us sort of think outside the box and sort of leverage technologies. We've seen a rise in patient navigation, where we've had specialist trained nurses or health workers picking up the phone, calling patients. There have been a number of strategies around, ensuring that drugs and medications are still able to reach patients. Sometimes you put them on a boda, you sign the whatever, but ensuring that we're still delivering care. I'm happy to note that we've had a lot of online support groups for patients initially where they'll be able to come and have a physical meeting. They're now able to log on to Zoom and that kind of thing. So we've definitely had to shift our focus in terms of care delivery. But I think we're actually able, by these kind of models, we've been able to access a lot more patients who might not necessarily have been able to travel. Of course, there's always a double-edged sword that you don't want the technology to worsen disparities. For instance, you don't necessarily want to be locked out if you don't have access to a smartphone, or I don't have a data bundle, then I can't access this care. So it's looking at how do we get the best bits of what we've learned during this and then apply that to our mainstream care delivery. I think the initial feedback has actually been largely positive, Mikhail, because patients are saying, the doctors, they actually feel that the doctors are engaged, the health workers are engaged, you're actually calling to find out how I am. This is brilliant. So I think those are the best bits that we can pick up and continue carrying forward, irrespective of when we return to what is now, the new normal. If you think about breast cancer and risk, I think there's two key points around risk. One, it's important to realize that having a risk doesn't mean you will get a cancer. And again, not having a risk doesn't mean you won't get the cancer either. And because sometimes we sort of put ourselves in a little comfort bubble, Nicole, and say, I don't have a risk, so I'm fine. No, we say, especially for breast cancer, if you want to know who is at risk, we suggest a mirror test. Stand in front of the mirror. If you're looking and you can see your reflection, you're at risk for breast cancer. Now, that risk might differ, but it's definitely there. Now, in terms of a broader approach to risk factors, Mikhail, you have factors that you may not necessarily be able to change, what we call non-modifiable factors, risk factors, and you have the modifiable risk factors. Now, one of the things that we consider non-modifiable risk factors, for instance, age. We know that as we grow older, what happens is that age in itself is an independent risk factor. So the older you get, the more likely you are to develop some of these cancers or even cardiovascular diseases and that kind of thing. You can't change the fact that you're female, right? Women, as we know, being female is a risk factor for getting breast cancer. It doesn't mean that breast cancer doesn't occur in men and they're still at risk, but the risk is much lower, but it does occur. So it's important for both our men and women to realize that. Family history, you may have heard of Angelina Jolie, and everyone sort of gets when we talk about family history. Again, just to put it into context, Mikhail, only about 10% or less of all breast cancers are what you call genetic, meaning there's a strong family history. You've had a relative, a mom, aunt, someone in the family have a cancer. That only accounts for about 10% of cancers. I would say the majority, 90% of breast cancers are what you call sporadic, meaning they just come up on their own, and meaning that we're all at risk, and that's why it's important to go for your regular screening where appropriate. Some of the other risk factors are where you have what we call dense breast tissue, where if you look at the tissue, how the breast is made up of glands, which are the ones that produce the milk, has a bit of fat, and the ducts that then transport the milk to the nipple area. Just because from an evolutionary perspective, the main function of the breast is to provide nutrition for baby. Now, if you tend to have more of that glandular tissue, what they call dense breasts, that in itself can be an independent sort of risk factor for breast cancers. We also have, like, if you've had, again, you have a previous history, a personal history of breast cancer, then, our antennae are more alert because you're at then slightly higher risk than, say, the general population. And it's important, even after you've had your preliminary surgery or therapies, to actually have continued follow-up. Again, things like, previous radiation, previous radiotherapy treatments for different conditions in your youth perhaps could could also contribute towards your risk. Now, those are the things that we can't do anything about. We always say the difference between, say, your friends and your family is you get to choose your friends, whereas you can't really change the fact that you're female, you can't change your family, you can't change the fact that we're all growing older. But so what can we really do in terms of sort of getting ahead of the game and, taking charge of our health? So the two things that ultimately make a difference, Mikhail, are diet and exercise. Those are the two key things that you can do to modify your risk. But what do we mean, for instance, by exercise? If we look at the World Health recommendations, Mikhail, we talk about 30 minutes of cardio at least 3 times a week, meaning it has to be something strenuous enough for you to feel breathless. But very few of us are doing that. And so we say, in terms of the approach to getting fit, because you're ultimately looking at a lifestyle change. What most of us are guilty of doing is saying, Mimi huyo kwa gym, there I am in the gym, 5 days a week for 2 to 3 weeks, and then your body's like, I don't know what your plans are, and you fall off the wagon. And so what we suggest is a more gradual easing into things. And we say 2 things. One, find something you like to do, whether it's swimming, whether it's Zumba, whether it's aerobics. Find something that resonates with you, because it's something that you want to sort of build into your life, and that will sort of keep you engaged. And then tell yourself, Mikhail, that I'm going to do this consistently for maybe at least 30 minutes, at least once a week, and do that consistently for 3 to 4 months. And then once you've sort of gotten the handle of things and your body is like, okay, we can handle this, then think about, how do I then increase that maybe to twice a week, and maybe maintain that to, about another 8 to 12 months. And then gradually in time, see whether you can actually build that into 3 times a week. And that's how you actually have effective lifestyle changes that actually make an impact. Now, when we talk about diet, what do we mean? Some people think diet equals supplements, and there's lots of things on social media, pepinos, wheatgrass, quail's eggs. But we say, as long as you're eating a balanced diet. And what do we mean by that? If you have an 8-inch plate, and we're saying 8-inch because some people sort of come now with us, and we're like, no. If you have an 8-inch plate, at least half the plate needs to be vegetables. But a key trick, Mikhail, is look at how you're preparing those vegetables. I mean, there's no nutritional value if you're going to torture those vegetables on the stove for 2 hours. That window has passed, right? So we say with the cruciferous vegetables, things like the broccoli, the cauliflower, the carrots, if you bite into it, it still needs to have the crunch. If you're looking at the leafy green vegetables, the spinach, the kale, the skumawiki, it still needs to be at that bright green stage before it turns to a darker green. And then we say a quarter of the plate needs to be carbohydrate. And so we always say, as a general guide, the less processed foods, the more nutritional value it has. So the more organic, the guashes, the arrowroots, the things. If you're looking to involve your try and incorporate more healthier carbohydrates. As a general guide, the less processed, the better. So if it's flour, the whole wheat flour is definitely more nutritious, the brown ugalis. And so incorporating these as well into your lifestyle. I mean, it's the same thing as the exercise. You're not going to wake up one morning and say, from this day forward, all chapatis are going to be brown. There's going to be protests, in the family. So it's looking at how do you build these gradually. So you say maybe start off with half and half white, half brown, and gradually try and incorporate these into your diet. The remaining quarter, it doesn't mean that, you can't, somebody's having a birthday, I can't have a slice of cake or a slice of pizza. We're saying as long as you're consistently having healthier choices, then, whether or not you have 1 or 2 doesn't really go much. I mean, because life still needs to go on, right? But it's just that you're making consistently healthier choices that actually stands you better in the long stead. Now, the remaining quarter needs to be proteins, and there's really, really good sources of plant proteins that we sometimes ignore, the beans, the peas, the legumes, and everything else. And we say if you're going to have animal-based proteins, then you generally want to lean more towards the lean, the white meats, the fish, the chicken. But if you are going to have red meat, at least try and limit it to 2 to 3 portions in a week and make sure that it's lean red meat. So that's the general bit around lifestyle and diet. And again, we always say as Kenyans, we love deals. We always want a bog off, buy one, get one free. So the bog off is this, because altering your lifestyle, altering your diet will not only decrease your risk of cancer, but will still ultimately decrease your risk of cardiovascular disease, which, as you rightly stated, is still the #1 killer worldwide. So you're basically killing two birds with one stone. So you're definitely investing in your future. That's a good question, Nicole, and that's the whole basis of screening. Now, when we talk about screening and early detection, it's important to distinguish between the two. Screening refers to picking up disease that is actually asymptomatic, meaning you don't have to feel anything. Now, I think it's important to mention this because sometimes our health-seeking behavior is our biggest barrier. Sometimes we say, I'm perfectly fine, why am I going to the hospital, right? Or sometimes we say, I don't want to go and look for trouble, right? Ignorance is bliss. But we're saying, ironically, you do want to go and look for trouble, because what we know, especially about breast cancers, you diagnose them early, treat them appropriately, the overall survival and prognosis is excellent. Now, so if you are in the screening age group, and this is based on our national data where we see average age of diagnosis of about 48 years, with an age range all the way from about 35 all the way up to 55, the screening guidelines are actually based on our age demographic. If you look at the screening guidelines, say in the West, you find that their screening probably starts from 50 or much later. But this is because women in sub-Saharan Africa and in Kenya certainly are diagnosed 10 to 15 years younger than their counterparts in the West. So you needed to come up with a screening program that's population appropriate and makes sense. And so if we look at in terms of the screening guidelines, we say ideally you from the age of 40, you want to go and have an annual mammogram in addition to what we call a clinical breast exam that's done by a health worker, whether a nurse or whatever. And then all the way up to 55, this needs to be on an annual basis. And then once you get to 55 all the way up to 75, it's to have the clinical breast exam and the mammogram, which is an x-ray of the breast, done at least every 2 years. And then once you get to about 75, it's more of an individual nuanced discussion that you're having with the patient around what are their expectations and the desire to continue with the screening. But so screening on its own is actually designed to pick up a symptomatic disease. Even in the best of hands, doing a clinical breast exam, for you to feel a lump, Mikal, it needs to be at least above 1 centimeter. Now, the rationale behind the mammogram is it's able to pick up lumps or areas of concern that you may not necessarily be able to feel. And so I would say, I think over the last 5-10 years, just because there's been such an increase, I think, in awareness and just having this percolate down to the population, we're definitely seeing more what we call screen detected cancers, meaning a patient doesn't feel anything, but then has an x-ray or mammogram done and you're actually able to pick up some pathology. So that's kind of what we're ultimately aiming for. Like, we're hoping to move our women to this stage where they don't have anything, but they're picking it up, we're sorting it out, and that's it. Now, as the disease progresses, what happens is that the most common presentation of a breast cancer is a painless breast lump. And I think it's important to emphasize that, Mikal, because quite a number of people have lumps and they're painless and they're like, oh, this is absolutely nothing to worry about. Now, to put it into context, 9 out of 10 lumps are not a cancer, but it's the 1 time out of 10 that you don't want to miss. So it's important to get all lumps, irrespective, evaluated by a healthcare professional. And even if we say this is a regular lump, it's fine, we can follow it up, then you have that information, as opposed to sitting on something that could be potentially managed much earlier and then having it progress. Now, as the lump continues, sometimes you may have non-specific symptoms like just a bit of discomfort. Again, you may have a nipple discharge, You may start, as the disease continues to progress, you start to see skin changes such as maybe swelling of the skin or looking like an orange peel appearance, what they call pud orange. But to be completely honest, those are like more advanced signs of more advanced cancers. So we really don't necessarily want to be getting it at that stage. Ideally, as we said, we want to be shifting to what we're calling the screen detected. But if you do have any breast signs, I mean, if you have any breast concerns or something just feels a bit off, it's important to get it checked out. Now, quite a number of people talk about pain. Pain usually is what you call cyclic, meaning it's hormonal and it changes from month to month. But if it's pretty persistent, it would still be important to get it evaluated by a healthcare professional. When you come in, in order for us to diagnose, we do what we call a triple assessment. And so what would typically come in, what would happen is that you would come in and see a healthcare provider, and they would typically take a history, do an examination, and they may or may not pick up some signs of breast concerns. Once that is done, they'll usually send you for some imaging, which could be, depending on your age, a mammogram like I talked about earlier, which is an x-ray of the breast, or they may sometimes do an ultrasound if you're below 40 years of age. Once that is done, and if the imaging shows something concerning, then they would do what they call a biopsy. And what we prefer to do is what we call a core biopsy, where we put a needle in, take a small amount of tissue, and have it submitted to the lab. So that's the diagnosis. Now, keep in mind that breast cancers and any cancers have the ability or have the capacity to spread to different organs of the body. And so the next thing that you want to know once you've confirmed the diagnosis, Mikhail, is what is the stage? You hear people talking a lot about stage of cancers and stuff. Now, what happens with the stage, what happens with breast cancers is that they have the capacity to spread to a couple of areas in the body. And the most common areas that they spread to are the lungs. Initially, they spread to the glands under the arm, which is the first sort of port of call, and they could potentially spread to the lungs, the abdomen, the liver, and the bones. And so usually the next stage, the next part of the process is confirming what stage. And then once you have the stage, especially for breast cancers, it's important to know what is the type of breast cancer that I have. Mikhail, when we say breast cancers, it's almost like saying painkillers. There's Disprin, there's Aspirin, and they all behave slightly differently. So not only do you need to know, to confirm the diagnosis, you need to confirm the stage of the cancer and the type of breast cancer that you have, because that has implications on the therapies that you're going to get. The next process is typically what we call a multidisciplinary discussion or a tumor board, where we sit down as a team, because there's many different aspects of treatment. Patients may require, depending on the stage and the type of cancer that you have, you may require surgery. You may require chemotherapy, which is medication you give through the veins, and that circulates and helps to control any cells that have maybe gone rogue. You may require radiotherapy, which is a special type of X-ray that sterilizes the area, and you may need what we call targeted therapies that are specifically designed for the type of breast cancer that you have. And so, as you can notice, I've mentioned all these different aspects. So all these different aspects are not handled by a single physician. There's, the pathologist there's a radiologist who probably takes the biopsy, there's a pathologist who confirms the diagnosis, there is the surgeon who maybe does the surgery, there's a medical oncologist who gives the chemotherapy and the targeted therapies, and there's a radiation oncologist who gives radiotherapy where needed. And so the first step, even before you have any treatment, Mikhail, is to have the team, the multidisciplinary team, sit down and discuss what is the best treatment plan for you based on the type of cancer that you have and the stage of the cancer. I think it's important to realize that irrespective of the stage, treatment is possible, right? Now, the goals of treatment might change. With earlier cancers, you're aiming to treat and cure, whereas with more advanced cancers, what we call metastatic, that have already gone beyond the breast and the glands under the arm, then the aims of treatment are mainly to control, but the treatments are available. So that's the first thing. So you have the multidisciplinary team sit down and discuss, and then agree on a treatment plan. Now, as we move to personalized medicine, and this is, I think, one of the bits that I'm really proud of at our institution, it's not enough to have a treatment plan, because the treatment plan has to come with a recognition that the patient is always at the center, right? So yes, we have this treatment plan, but it's important for us to communicate this treatment plan to the patient and, their caregivers and support system, and sort of resonate with the patient and say, okay, this is what we're thinking, but what would you like? What would you feel you would be most comfortable with? Because at the end of the day, we're partners, but it's the patient who's actually walking that journey. So the patient needs to be engaged and actually understand what the whole aims of the treatment are, and to make informed decisions about what is the best treatment strategy for them. Our role is there as health workers is to facilitate their understanding of the disease, walk the journey with them, and help to best support them to make an informed decision about their care. So we have a multidisciplinary breast clinic that's complementary, where the patients come in, are able to sit down with their families and talk to the entire team, the surgeon, the medical oncologist, the radiation oncologist. And I think the initial response that we've had has been largely positive. I think patients sort of appreciate that 30,000 feet view, rather than this is the big picture. We're going to, as with any journey, you want to know, I'm starting off from here, do I need to carry supplies? And so I think it's important to always try and personalize that experience. And again, it's important because the exact same cancer in, say, Mary might be treated completely different from Jane. And sometimes patients come in and say, okay, my colleague, my friend is getting this, why am I not getting it? So you're like, no. It's a different type of breast cancer. So there's all this nuanced approach to treatment, and it's important to have that upfront before the treatment starts. Again, a key part that we sometimes maybe don't talk often enough about is the psychosocial support. And so it's important to sort of view the patient holistically. It's not just the treatment. We always say as clinicians, our aim is not to make the treatment or the cure worse than the disease. And so it's trying to take a 360 evaluation of what are the things that you require. So typically how we help to support is you would get nutritional support, advice on diet, counseling as well, because it is a tough diagnosis. I mean, it's a diagnosis that we've had, our warriors go through successfully, but it's still a heavy diagnosis. And even just having the diagnosis is typically like going through the stages of grief, right? You sometimes maybe go through denial, or sometimes you go through anger. You're like, why is this happening to me? I don't drink, I exercise, I do this and that. And sometimes you sort of get into bargaining, where you're like, if I do this, will this happen? And then you gradually sort of work your way down. Sometimes some people go into depression, but you gradually work your way to acceptance. So it's not a sort of like just a linear progression. You sort of sometimes go back and forth. So even the mental support for our patients is absolutely critical. And I think I'm mentioning this because I think it's important that we normalize the mental health and wellness for patients, because sometimes I find that there's still a lot of stigma around mental health concerns, that sometimes if you tell a patient, listen, I think you need some support, you're like, no, I'm fine. I don't want to be seen, going to a psychologist or whatever. And we're like, no, this is an integral part of the process, and all these therapies and body changes and stuff, you're dealing with a major life event. And so, and particularly women, for instance, they want to be strong for everyone at home. Like, she's the mother, she's perhaps a breadwinner, she doesn't want to go home and say, listen, I'm not coping with these therapies, I'm really struggling. And we're like, you don't have to struggle. We actually have the resources to help support you through this journey. And so we encourage our patients as much as possible to get counseling and support, get their families on board, because everyone needs to be on the same page. There's still a lot of sometimes secrecy where nobody wants to reveal their diagnosis, and we say try and get a support system, because we know that that support system, I mean, the doctors can do their bit, but definitely patients who have the psychosocial and wellness support tend to do much better. I mean, I think the challenge has been that cancer care isn't cheap anywhere in the world. Part of and this frequently results in, as we said, catastrophic health expenditure or financial toxicity for patients. And so we've had a couple of mitigating strategies, especially around the National Hospital Insurance Fund, which, as I had mentioned earlier, has actually made a huge difference in sort of having more patients continue their continuum of care. But I think we've also starting to embrace, and there have been several pilots that have been trying to look at the feasibility of universal health coverage, right? And I think in order for us to look at or try and mitigate some of the costs, I think it's important to think of cancer care and treatments beyond just the scope of health. Some people think it's just the purview of the Ministry of Health, but I believe there are all these facets that would help to mitigate some of the costs. You need to involve the educators, because if they're able to know from an early age the signs and symptoms of cancers, then they're not necessarily going to ignore them. They're going to come in early, which means, less costs, less maybe extensive therapies. You do need to rope in financing, because then they need to think about so if we're looking at universal health coverage, then what are the systems we're putting into place to help to sustain or invest, do health investments that will actually help care to improve. So all these different facets, we have to look at nutrition, we have to look at all these different, how are we being more proactive about our health? How are we building towards the preventative aspects of care that definitely make a difference? So I think it's definitely a much broader picture than just looking at the health funding per se, but looking at how we can bring all these stakeholders to the table in order for us to really, really start to get a definite crack at addressing the elephant in the room, which is basically the cost of care. What advice would I give to caregivers with patients at home? I think, and first of all, a big shout out to all the caregivers and who've been helping to support our warriors. I think one of the first things that we frequently, one of the questions that we get frequently asked is, how can we as friends or family best support our cancer patients? And I think sometimes it's as simple as just being there. Sometimes you think I have to do all this, complex things or whatever, but sometimes patients just appreciate the fact that their families are there. They're treating them as they would even before their diagnosis, having their normal life continuing. And sometimes we say, yes, we can fundraise, but it's not about the money. It's about being human and connecting, and taking the time just to walk in the patient's shoes. For instance, sometimes patients maybe have to go in for therapies. They're not necessarily able to pick up their kids from school, or somebody knows that on Tuesdays my children have chapatis and maybe they're tired, they're no longer able to cook. It might be something as simple as picking up the kids, or maybe dropping the groceries, or maybe saying I'm going to make chapatis for her on Tuesdays, just so that life continues as normal and her kids are not disappointed. So it's the little things that actually go a long way towards making a difference. And then sometimes caregivers come and say, what should I say? And we say, we don't have to say anything. Just be there. Just be there. That's what makes a difference. My comment on the national screening guidelines, I would say that it's definitely the first step towards trying to define what our population needs are, and trying to define how best to sort of screen for our populations. But ultimately, the devil's always in the details. It's not in the guidelines sitting in the, on the shelves and looking pretty. It's the actual implementation of those. And that's again why I said we're super excited today, because we're going beyond looking at the guidelines. We're going to the next step of how do we then implement? How do we, again, it's not just implementing. What are the markers to show that we're actually winning, the battle against this? What are the metrics that we're using to ensure that we're actually seeing more and more patients getting diagnosed early? And so I think it's exciting times. I'm looking forward to sort of seeing how that percolates on the ground, and as health workers and professionals, we are committed to supporting the ministry and the National Cancer Control Program to sort of see how we can actualize this for the Wanjiko and Fatma on the ground. Two parting shots. One, I think there's always hope. I think it's important to realize that there's always hope and there's always treatments available. I think for the longest time, the narrative in our region has been cancer equals death. And we know that that is not true at all. Irrespective of the stage of the cancer, there are treatments available, and if treated, detected early and managed appropriately, breast cancers have a really, really excellent prognosis. The other thing I would say is it's important for us to take charge of our health. I think somebody had the analogy about, for those who drive, and they said we treat our cars better than we treat ourselves, because every couple of miles you take it in for a service, right? Whereas with our bodies, we wait for the car literally to break down, and then we tow it, to the hospital for care. And so I think it's encouraging ourselves to take charge, learn about, go to a healthcare worker, learn about breast awareness, learn about how to do a self-breast exam, take charge of your health. We always say we can tell you, come in once a year for screening or whatever, but from 1 year to the next, the best guide of what's going on with you is obviously yourself. So let's take charge of our health. Let's not ignore signs and symptoms, and let's go for screening where appropriate.
Thank you so much.
Okay, thank you.